Welcome to my YouTube channel. Today we are going to talk about preeclampsia. Kindly make sure you subscribe, it will cost you absolutely nothing. And we are going to begin with the pathophysiology, and first we will deal with the risk factors. And the risk factors, we have divided them to maternal, and we also have divided them into fetal. So in terms of maternal, we have late maternal age. So if already you are greater than 35 years old and beyond, primigravida, that is the first gravid. We also have new paternity or new partner. So if this is new partner compared to the other previous pregnancy, genetic factor or family history. So if your mother had an history of preeclampsia, or you have had a previous pregnancy which had preeclampsia, and this is just what I was saying, that's previous history of preeclampsia. And in the in terms of fetal, we have multiple gestation. So next we're going to talk about etiology. In terms of etiology, it is unknown and it is considered to be multifactorial, meaning a lot of factors are involved in terms of causing the etiology. In terms of multifactorial, you have genetic, we have immunologic, we have hormonal, and we have environmental factors. So we're going to begin with the pathophysiology, and before we begin the pathophysiology, we're going to do the physiology before we do the patho, the bad part. So the physiology, we have invasion of the spiral artery by the trophoblastic tissue, and then that will result to visualization of the myometrial and decidual segment of the spiral artery, which will later result in the replacement of the muscular and elastic layers of the spiral artery, followed by fibrinoid and fibrous tissue, which now will result to large tortuous and low resistant channels that will extend through the myometrium. So in terms what I'm just talking in terms of the physiology, this is the normal pregnancy, and these are the spiral tissues. So the spiral arteries will invade the decidual, that is the decidua, and will have large tortuous and low resistant channels. This now will enable blood flow to flow from the mother to the child. And as you can observe, these are large and tortuous, meaning they are low resistance. In comparison to preeclampsia, which there is abnormal decidualization or there is abnormal invasion of the trophoblastic cells, which will result to narrow, if you can say these are narrow channels, which are high resistance, therefore causing preeclampsia. So we now go to the abnormal part, where we have inadequate trophoblastic invasion, as I previously mentioned. And with this, you are going to have, so where we had dysregulation of the myometrial and decidual segment of the spiral artery, now we will have it just limited to the decidual segments of the vessels. And later we will have high resistant uteroplacental circulation with subsequent impairment of the uteroplacental perfusion. And this now will cause preeclampsia, and in later we'll have formation of radicals, and then we'll have later inflammation and vasoconstriction in the mother. So this is another image just showing us what we have just explained, and this is the normal tissue where we have invasion of the trophoblastic cells into the decidual of the mother, into the decidual, as you can observe here. And as a result, we are going to have large tortuous tunnels that are low resistance. And in comparison to preeclampsia, where we have abnormal invasion of the trophoblastic cells, and you are going to have reduced blood flow or small channel, narrow channel, which are high resistance. And these channels are going to cause reduced blood flow into the mother, and later now you can have things like apoptosis, oxidative stress, and later you have mitochondrial dysfunction. And this stress in the syncytiotrophoblasts are going to cause cytokines to be released, which will enter the bloodstream, and after entering the bloodstream will cause inflammation and vasoconstriction. So just what we have said, that is high resistance uteroplastic circulation with subsequent impairment of the uteroplacental perfusion, as we've left. And then you're going to have placental ischemia. After we have had placental ischemia, we are going to have oxidative stress and production of toxin, which will now enter the circulation. Later, you're going to have widespread inflammation because of this oxidative stress and production of toxin, which have now entered the circulation. You're going to have now widespread inflammation into the mother's side, and endothelial injury and dysfunction leading to altered permeability and vasoconstriction. When you have altered permeability and vasoconstriction, what will happen? We'll have extravasation of fluid from the intracellular to extracellular, and inappropriate activation of the coagulation pathway. In addition to that, we also have widespread vasoconstriction, as we said, and this is going to cause systemic hypertension and ischemic in the vascular vessel, and this is just what we called preeclampsia. In addition to that, we see that we are going to have altered permeability, and this will result to extravasation of the fluid from the intracellular to extracellular. And because we said we are going to have inappropriate coagulation system, you are prone to have intravascular coagulation with progressive consumption of the coagulopathy. So widespread constriction is going to cause systemic hypertension and ischemic in various vascular bed, and this will result to the first thing that we're going to talk about is the head. So neurological impairment, this will now cause the systemic hypertension and ischemic in the various vascular bed in the head is going to cause intracranial pressure. Now, when we have intracranial pressure, it will present with the following: visual field disturbances, new onset headache, hyperreflexia and cornax, and seizures, which are now going to present as eclampsia, which is kind of a complication of preeclampsia. In liver, we are going to have liver impairment, and what will cause it is because blood will accumulate in the venous system of the liver, and this will cause liver enlargement. In addition to that, if liver enlargement occurs, you're going to have elevated liver enzymes and low platelets and hemolysis. In addition to that, this will present as epigastric pain because of the enlargement, and because you said we are going to have elevated liver enzymes, we have elevated ALT and AST levels. In addition to that, this elevated liver enzymes and low platelet and hemolysis is a complication called HELP syndrome, which I've talked about in one of the videos that I've made. So in terms of renal impairment, you are going to have glomerular arterial vasoconstriction. We said you are going to have widespread vasoconstriction or systemic hypertension and vasoconstriction. So in terms of impairment, we also in addition to the alveolar vasoconstriction, we're also going to have altered glomerular capillary permeability, and this will cause us to have proteinuria. And meaning if we will have proteinuria, then we are going to have proteins in the urine. So we go back where we said glomerular arterial vasoconstriction. When you have a glomerular arterial vasoconstriction, then you are going to have decreased glomerular filtration rate. And in terms of that, then we will have, if we are not going to filter, then we will accumulate toxins that include urea, creatinine, and urate. So when we are doing one of our laboratory tests, these three of them will be elevated in our bloodstream. So, and this, in addition to that, will also result into acute kidney injury, which is one of the complications of preeclampsia. So, in addition to that, because we have decreased volume filtrate, we are going to have decreased urine output, and that will present as oliguria or even anuria, where we don't have production of urine. Oliguria is few production of urine. So we go to the other pathophysiology, which is said is extravasation of fluid from the intracellular space, and the first thing that is going to cause is edema and weight gain for the mother. And then we also have pulmonary vasoconstriction and pulmonary edema, and this is going to present as crackles and shortness of breath. In addition to that, in terms of the eye, it can also present as papilledema. And with that, we go to the other pathophysiology, that is the intravascular coagulation with progressive consumptive coagulopathy, and this is going to predispose the patient to have thrombocytopenia. This is because of the consumption of the thrombocytes. And lastly, also in addition to that, because we said in preeclampsia, you're going to have placental perfusion and ischemia, and this is to the fetus. We are going to have intrauterine growth restriction, which is usually asymmetrical. We also have intrauterine fetal demise, oligohydramnios, that is small production of the hydramnios fluid, and the fetus will be predisposed to placental abruption. So I have another slide describing the pathophysiology of all of these. So this is the pathophysiology in terms of the fetus. We are going to have ischemia, that is the placental ischemia, meaning you are going to have reduced perfusion to the fetus. And when you have reduced perfusion to the fetus, you are going to have decreased decreased filtration of fetal blood, and as a result, we are going to have decreased urine excretion into the amniotic sac, and as a result, you are going to have oligohydramnios, which is measured in terms of ultrasound, that is AFRA of less than 5 centimeters, or deep pocket of less than 2 centimeters. So in addition to also have decreased perfusion, you also have going to have decreased or no adequate nutrients because there's decreased perfusion to the fetus, which will result to fetal growth restriction, which can result to intrauterine growth, intrauterine fetal demise. So in terms also of ischemia, which is going to produce toxin, you can also have placenta inflammation, and you also have increased resistance of blood flow to the placenta from the umbilical arteries, which will result to absent or reserved blood flow in the umbilical arteries, which will now be an indication when you measure through this in an ultrasound. This can be an indication for induction of delivery. So in addition to that, you're going to have fragile ischemia is going to cause us to have fragile vascular connection between the placenta and the uterus, and this is going to cause easier separation of the decidua basalis from the fetal vessel, which now will cause placental abruption. Placental abruption will present as vaginal bleeding and uterine pain. And in addition to that, you're going to have immediate fetal stress to the fetus, which will cause us to deliver. So grades of preeclampsia, in terms of grades of preeclampsia, the severity of preeclampsia can be graded by, number one is the diastolic and the systolic blood pressure. So is it high, is it low, where are we ranging in? The amount of proteinuria, it's actually the presence of proteinuria, the signs and symptoms of severe preeclampsia, lab results indicating renal and liver disease and clotting deficiency. So in terms of renal, as we said before, you're going to have increased urea, increased urate, and increased creatinine. In terms of liver, you're going to have elevated ALT and elevated ALT. In terms of clotting deficiency, you are going to have, in terms of when you do your blood count, you are going to have thrombocytopenia. So presence of convulsion, which we said is one of the complications of preeclampsia. So in terms of severity, we are dividing severity into two, and the first one is mild preeclampsia or preeclampsia without severe features, and this is where you have BP ranging from 140 to 159 and diastolic ranging from 90 to 109 millimeters of mercury, and you have presence of proteinuria alone. While in preeclampsia with signs and symptoms of severe disease or severe preeclampsia, is when you have the following, and the first one is when you have BP of 160 over 110 millimeters of mercury on 2 occasions 4 hours apart, or when you have a BP of 170 over 120 millimeters of mercury on 1 occasion, or when you have severe features and abnormal laboratory results indicating severe disease. In the next slide, we are going to talk about those severe disease or severe signs and symptoms. So the severe clinical features of preeclampsia, what we have been talking about, this is kind of a repetition. If you have grasped the pathophysiology, then you are going to grasp the science, the clinical features. So symptoms, if you remember, we said neurological impairment, and one of the severe symptoms is severe headache, visual and flashes of light seen in front of the eyes, blindness, dyspnea. When we said that we are going to have extravasation of fluid from the intracellular to extracellular, when it will cause pulmonary edema, it can present as dyspnea. Altered mental status is in the head. Upper abdominal pain in epigastric or around the liver. When we said we are going to have liver impairment, which will present as epigastric pain. And now we go to the signs and symptoms, which you are going to have tenderness over the liver. This is just epigastric pain, but now in terms of signs. You're also going to have increased tendon reflexes or knee reflexes and clonus, pulmonary edema, which you can observe in terms of auscultation, or when you're doing your respiratory exams. You also can identify ascites in your abdominal exam. And in terms of the laboratory signs, it's just a repetition. We said we are going to have elevated creatinine, elevated urea, and elevated uric acid. In addition to that, we are also going to have elevated proteinuria. So in terms of liver, also in terms of renal, we said we are going to have a serum creatinine of 90 millimoles per liter or more, indicating abnormal renal function. In terms of liver, we said we are going to have elevated LT and ST, that is an alanine aminotransferase or aspartate aminotransferase of 40 international units, indicating liver disease, and platelet count less than 1,000 millimeters microliters. Management of preeclampsia, we're going to begin with the prevention of preeclampsia. In terms of the prevention, these are mothers who had previous history of preeclampsia or maybe has a high predisposition of having preeclampsia. So what we give calcium supplementation. In addition to that, you give baby aspirin, that is which is antithrombolytic, and the dose is usually 81 milligrams. And when you initiate it from 12 weeks, and then you give it to 28 weeks. In addition to that, you ensure that the mother has good prenatal care and regular visit. And our goals of management, in terms of managing preeclampsia, we have 3 goals. And the first one is the prevention of convulsion. And how you prevent convulsion is by giving magnesium sulfate. The other goal is regulation of blood pressure. This is by giving antihypertensives. The other one is delivery, and delivery is usually the definitive goal or the definitive management. So as you are managing this patient, your mind should be deliver, because what is our problem in preeclampsia? Our problem is the placenta. So before, as we treat, we normally first of all check at the severity, and we see that severity is divided into 2: mild and severe preeclampsia, or severe preeclampsia, or preeclampsia with severe features, and preeclampsia without severe features. And in terms of mild, this is when the patient has BP which are elevated but not much elevated, that is BP less than 160 and less than 160 and 110, and they have proteinuria. So what you do, you ensure bed rest and daily monitoring. One of the pathophysiology is extravasation of fluid from the intracellular space to extracellular space, which will cause the patient to increase weight and edema. So you monitor the weight, ensure you monitor the weight to see if the patient is progressing, has a worse prognosis, or the patient is progressing well. Hospitalization and home regimen antihypertensive to regulate the BPs. Daily monitoring, daily urine dipstick measurement of proteinuria to see if our proteinuria is increasing or not. Blood pressure monitoring to see if our BPs are increasing or not. Fetal heart rate testing to see what is the state of the baby. One thing that I tell patients is kindly make sure that the role that the patient has during that time is to see if the baby moves, so they can count the number of movement that the baby has moved. In addition to that, periodic 24-hour urine collection should see to see if our kidneys are well functioning or we are moving to oligourion and anuria. We also do ultrasound, that is obstetric ultrasound. In addition to that, to ensure liver function, renal function, and coagulation profile is also done. And delivery is our definitive management in terms of preeclampsia. So in terms of preeclampsia with severe features, so immediate delivery of preeclampsia after stabilization has to be done for the following mothers. And the following is if the pregnancy is greater than 37 weeks of age, or the patient has gone to eclampsia, you have to deliver immediately, or the preeclampsia with severe features, and if the pregnancy is greater than 34 weeks, or we have deteriorating renal, pulmonary, and cardiac and hepatic function of the mother, or we have non-assuring fetal status. And in terms of now, because in the previous slide you have talked about now when to deliver immediately. So in terms of severe patient who comes in with severe preeclampsia, the first thing you have to assess is indication for immediate delivery. And as we said, when a mother has pregnancy that is greater than 37 weeks, when a mother comes in with eclampsia, when a mother comes in with preeclampsia with severe features, and if the pregnancy is greater than 34 weeks, when the mother comes in and we have renal, pulmonary, and cardiac hepatic function, deterioration of those factors, and when the mother comes in, the fetus is in non-reassuring fetal status. So you assess. So do we have to do immediate delivery? And if these factors are present, then that is yes, you have to deliver. However, if it is absent, if it's absent, you assess the age of the child. And if the age of the child is greater than 34 weeks, then you also deliver. However, if the age of the child is less before viability to 34 weeks, then you have to consider the following. You assess the maternal and fetal status, and if the maternal and fetal status are stable, then you administer corticosteroids to prepare for delivery. And administration of corticosteroids is to prevent RDS, to prevent IVH, that is interventricular hemorrhage, and to prevent NEC, that is necrotizing fasciitis. In addition to that, you strict monitor the maternal and fetal status to see if they progress to unstable. And in addition to that, you also consider a trial of expectant management. That is, you manage as the patient who came in with mild preeclampsia. However, if the mother comes in and is unstable, then you consider the health of the mother first, and that is, you stabilize the mother and proceed to deliver the baby. So indication for termination of the pregnancy, this is when you have preeclampsia close to term, as you said before, that is greater than 34 weeks, impaired maternal end organ despite of the age of the baby, as we stated before here. Even if the baby is between viability and 34 weeks and the mother is unstable, then you deliver the mother. Or when you have compromised fetal growth and impaired placental function, in addition to non-transitional fetal status, or when you have eclampsia.